in being treated as a bit of an outcast by some people. And there are some people who have not spoken to me in public health since I joined the industry. But being treated that way and having to kind of think hard about, was I still working in public health in a commercial company, made me think, well, yeah, actually I am. And actually, all I've done is I've changed to a different working culture and I've reframed the problem from a different perspective, but I'm still working for that. And it made me realize that there's more in common in the world than there is that's different. And if you just take the time to look at things from somebody else's perspective, then you will see a lot more in common than you will see that's different.
So, welcome to a special new series of episodes that we've launched in partnership with the Faculty of Public Health. So, in this series, we aim to explore one key question: what is public health? Now, it may seem like a simple question, but public health is no single thing. So, this series aims to shine a light on the huge range of work delivered by the diverse public health workforce as we talk to key figures in public health from across the UK to explore this question, as well as what's inspired them to go into public health and what they think are the key challenges lying ahead. So it's my absolute pleasure today to welcome Professor Sir Jonathan Van-Tam. Professor Van-Tam is very well known to many in public health. He's currently a Professor of Health Protection at the University of Nottingham and the former Deputy Chief Medical Officer. Jonathan completed his medical training at the University of Nottingham, where he also became a senior lecturer. He then joined SmithKline Beecham in 2000 as an associate director, and he has over 2 decades experience in health protection and infectious diseases through his roles, for example, as the head of pandemic influenza at the then Health Protection Agency, chairing the ECDC expert advisory group on H5N1 vaccines, as well as chairing the UK government's new and emerging respiratory virus threats advisory group. Professor Van-Tam also received an MBE in 1998 and was knighted in the 2022 New Year's Honours List. He was also awarded the David Attenborough Award by the Royal Society for Outstanding Public Engagement in Science, and was also awarded the Freedom of Boston Award in 2022 by his local community. It's an absolute pleasure to have you on the podcast, and thank you so much for coming on.
Thank you.
So perhaps maybe let's start with a little bit about your career in public health. You've had an incredible career background. You've worked across academia, government, as well as the private sector. How would you describe what first inspired you to pursue a career in public health?
So when I got to medical school, the thing I wanted to do was to be a GP. And at Nottingham, at the time, every single medical student was forced to do an intercalated Bachelor of Medical Sciences, so a kind of BSc, which involved a research year. And it was almost a year in those days. And you had to choose a home department to go to. And lots of people chose anatomy or physiology or biochemistry and so forth. But those weren't really subjects I was terribly good at medical school. And I chose what was then known as community health. And so I basically had, in my third year of medical school, almost a year, which was given over to, first of all, studying epidemiology and public health in a more detailed way than you'd normally get in a medical course, and doing some public health related research, which I actually did on motorcycle accidents. So, and adolescent use of motorcycles. So absolutely nothing to do with my later career in terms of respiratory viruses. But what that year did was it kind of hooked me on epidemiology. It hooked me on population health. It hooked me on research and generating new data. And it hooked me on the process of writing that up for publication. I somehow managed to publish 3 papers as a result of that year spent in epidemiology. So that lit a fire that didn't quite go out during my clinical training. And at the end of medical school, I went to see the then Professor of Public Health and said, look, I think I want to do public health eventually. And he said, "Okay, do you enjoy being a proper doctor?" And I said, "Yes, I do." And he said, "Well, go away. I don't want to see you for 5 years. I want you to go and get clinical medicine out of your system, because it's going to be really important to do that before you go into public health." And that was good advice. And I did that. And literally 5 years later, he contacted me and said, "We're about to advertise lecturers' posts, which is part of the public health training pathway. Do you want to apply?" And I applied, and I got a post. And then I trained basically as an academic registrar in public health, went down the academic track. That's what got me into public health. And then an amazing thing that doesn't exist, I don't think, anymore, just before I took that lecturer's post, was I got onto an SHO post, a rotation in public health in Leicester. Pretty unique at the time. And you rotated through the local authority public health department, or as it was then, health authority, and you also rotated through infectious diseases and a couple of other clinical specialties. And I got into respiratory viruses as a public health problem then. So a long while ago, and that kind of again lit a fire about how interesting it was to study respiratory viruses. So I kind of went into public health training with a kind of ready-made specialist subject of respiratory viruses.
Yeah, I mean, I guess moving from clinical medicine to public health, when you reflect now, do you miss clinical medicine now? Are there aspects of it that you sort of miss the patient contact?
Oh, yes, well, I miss it desperately. And right through my public health training, I continued to do a half day a week in the emergency room all the way through. It was allowed in those days.
Yeah.
And so I was a clinical assistant, half a day a week, and sometimes kind of filled in at night on the emergency medicine rota when they were short. So I kind of kept all that up all the way through my public health training. And I do miss clinical medicine, and I do miss the patients. Yeah.
Yeah. Also, the story that you said about your sort of mentor or professor that you had, that you followed his advice of getting the clinical medicine out of your system over those 5 years. But what was it about that? That's quite a big decision of following your professor. What was there something about that professor or that mentor that sort of inspired you to follow that advice? Because we get advice from a lot of our sort of seniors at that time, right?
Yes, you do. And so the professor's name was Professor Richard Madeley. Many of the older people in public health will remember Richard. Unfortunately, he passed very soon after he retired. He didn't really have a long and enjoyable retirement. It's such a shame. But he was I sensed he was a wise individual who had spent a lot of time studying systems and how they worked and how to work within them. And I just felt that his advice was, just sage and measured, and that he could take a long view on things. And we got on as people as well. And it's very important that you warm to people who you get on with, who you find some common ground with. So when it came to me using analogies at number 10 Downing Street, literally spontaneously, I had to kind of try to dig out in my memory where this kind of first came from. And I think I have to attribute it to Richard Madeley, who was a Nottingham Forest diehard supporter, season ticket holder, and a great football analogist in terms of explaining how to get things done and how to make things work in the public health world. So I'm going to give him the credit here officially on this podcast for where that came from.
Yeah, it seems like you both kind of bonded over that love of football, which we will get to in future questions. You mentioned a bit about your inspiration to come into public health. We'll get to a little bit about your different experiences that you had across sectors. But perhaps let's get to, I guess, the main question that we partnered with FPH on. It may seem like a simple question, but in the episodes that we've done so far, it's proved quite complex of a question to answer, because public health is no single thing. But I guess in your own words, how would you define what public health is?
I think I would define it, and I've thought about this obviously before this interview. I would think I would define it very, very broadly in terms of works that contribute to enabling the population to live long and healthy lives and to live more of their life in good health than in bad health.
Would your definition of public health be different at the beginning of your career versus now?
COVID has focused all our minds on mental well-being and how actually mental well-being and mental health is part of public health. I think that's more prominent than it was a couple of decades ago. I think the tools available are different. And you mentioned big data and you mentioned AI, and there are definitely a couple of things that undoubtedly have increasing relevance as we move into, the kind of next few decades. But I don't think my sense of what's involved has really changed.
Yeah, the goal is the same. You gave a very, very interesting lecture when you accepted your Royal Society award. I think that was last year, where you sort of reflected a bit about the different roles that you've had in your career across different sectors and organizations. And you said something really interesting about the idea of collecting different lenses to look at the same world. What did you sort of mean by that? Why do you think it's important to get those experiences across different organizations?
Well, I suppose it was driven initially by, frankly, a small portion of the public health world treating me and others like me like an outcast when we went to work for the pharmaceutical industry, as if this was some, kind of terrible crime against humanity to work for a kind of commercially focused organization. But I quickly worked out, particularly with vaccine companies, that, and the vaccine company I worked for, Sanofi Pasteur MSD, that up until the pandemic, some of my best work ever in public health was delivering new vaccines that improved population health, particularly in the childhood schedule, particularly getting the polysaccharide pneumococcal vaccine into the UK schedule, things like that. They made big quantum increases to the kind of good health stock of the UK population, and I think it kind of stems from that in being treated as a bit of an outcast by some people, and there are some people who have not spoken to me in public health since I joined the industry, but being treated that way and having to kind of think hard about, was I still working to, in public health in a commercial company, made me think, well, yeah, actually I am. And actually, all I've done is I've changed to a different working culture and I've reframed the problem from a different perspective, but I'm still working for that. And it made me realize that there's more in common in the world than there is that's different. And if you just take the time to look at things from somebody else's perspective, then you will see a lot more in common than you will see that's different. I enjoyed that transition out of the public sector into the private sector. I then enjoyed the transition of working in the world, in and with the World Health Organization, running a collaborating centre in Nottingham and working as a WHO consultant for many years. I enjoyed the cultural change again, going to a kind of national public health agency in terms of the PHLS, the HPA, and then Public Health England, and then going to government. And it was just really different ways of looking at the world, but essentially the same health protection world in my case.
Yeah.
And you know what? When the chips were down, when we had to find vaccines for the UK as quickly as possible in that big crisis, then having had that experience and being able to bring to bear that experience from the industry, from WHO, from public health agencies, and from academia into that government role was massively, massively advantageous. So, my kind of message to registrars is, look, where it suits you personally and professionally, where the opportunities emerge to kind of cross working cultures, in the public health space. Just do it.
It's interesting that you said about being a sort of outcast from having that experience. Why do you think that is? Why do you think public health professionals may see going to the private sector as a sort of, no-go area almost?
I think there's a kind of sense that in public health we believe that health and access to healthcare is a kind of universal right, and that people shouldn't not have access to healthcare because of their wealth. That then gets tied up with the idea that it is kind of bad to make a profit out of providing health to others, including providing medicines and vaccines and so forth. But we live in a world where state, medical manufacturing, whether it's medicines or vaccines, has just simply not survived. And the last public vaccine institute that I can think of was the Statens Serum Institute in Denmark that has now also gone. So we live in a world, or we've set ourselves up in the Western world at least, with a system where we are dependent upon the private sector to produce medicines for us and to discover medicines for us and industrialize them. So it's just part of our ecosystem.
Yeah, and I guess really, as you said, COVID-19 and the mRNA, vaccines, maybe, do you think it's probably changed people's minds of the benefits of having that lens on public health? I know that you've probably said in the past around, if COVID-19 happened in 2015, we would not have had the technology ready to be able to respond in that way. So it kind of shows the role that having that lens can have on public health and impact.
That's absolutely right. I don't really think the messenger RNA technology would have been ready in 2015 to deliver at scale. And pandemics are not lucky, but that was a bit of luck, if you like. That was already. Of course, it wasn't luck. It was people investing and people, seeing the potential in that kind of medicine. The other thing to say is that within the vaccine task force, there were very few barriers between the public sector and the industrial sector in terms of trying to move at the greatest and safest possible speed to get vaccines. And, we couldn't have done that if there were loads of barriers in the way. So they had to be very close working. And I think it's really demonstrated a new model that's going to be important for the future. And, the UKHSA Vaccine Development and Evaluation Centre at Porton Down, that's just been announced in the last month or so, is really a testament, I think, to that changed thinking, that we're going to get more done in partnership with the private sector, particularly in the vaccine space, than we are by having this kind of, artificial gap where the public sector waits for stuff to be ready and then kind of tossed over the fence, and then we buy it if we want to. It's better to engage much earlier and much more intimately with what you want for public health, and then what the solution might be.
So a little bit about again about going from those different lenses, and I've heard you sort of reflect about your career, that when you're in that stage of career when you were discovering which path to go down and what sort of made you tick, you realized that for you it wasn't about being good at one single thing in terms of expertise, but you liked the idea of being a translator across different sectors. What did you sort of mean by that, and how did you learn how to translate across private sector versus academia versus public sector?
Well, you kind of start where you are, I guess. And I suppose that journey began with first moving to the industry and explaining to people who were developing medicines and people who were selling medicines in the commercial side of the industry that public health people don't think that way. This is how we would see what you're offering. It would be different to us. And, let me kind of, translate what I mean by that into commercial language or into clinical development language. Let me explain what I mean by the public health world wouldn't be particularly excited by what you're doing, blah, blah, blah. And then in turn, being able to go back into a public health space and say, well, look, industry wouldn't see it like that because they have got, a very, very rigorous framework around clinical trials and regulation. So they couldn't just do this study, or they wouldn't want to do that study because X, Y, and Z. It wouldn't appeal to them. They wouldn't get shareholder backing for it. The board wouldn't back it. And so what I'm trying to do is explain somebody else's world to another world. So, but you can't do that unless you cross into it and you kind of live it a bit.
So you've sort of mentioned it already about your analogies, and I think everyone sort of knows you from those COVID-19 press briefings. And it was very clear that during the pandemic, the public became very interested very quickly in public health data, in epidemiology. But also this clearly brought a lot of attention to individual personalities such as yourself, Chris Whitty, Patrick Vallance, Kevin Fenton, and many, many others. I guess reflecting back on that time, how did you, I mean, as public health people we kind of shy away from the limelight, I would say, as the sort of typical personality of a sort of public health person. But how did you sort of process that period and that sort of newfound sort of public health celebrity status? Because it seems like, British culture seems to love a sort of celebrity. Did you enjoy that sort of period?
Some of the attention was unwanted, but there was a degree of satisfaction in knowing that, I think I knew anyway, I think that was the feedback, that I had at least met some people at their point of need and been able to kind of help them understand a really complex and frightening set of circumstances. And I found that most people were looking for that moment when they could say, I get it now. I know what you're asking me to do. I heard that a long while ago. Now I get why you're asking me to do that. And I get to see what the kind of ultimate goal in doing that is. So it's just kind of, again, just kind of reframing it, playing it back, and going at it from different angles until you feel your audience has gone, right, I get that now. You've given me information for action. You've given me something I can process, something I can make relevant in my own world in which I live, which might be very different to the person who's giving the advice. But that's the moment you're looking for when your audience, you hope they go, right, I get it now. I know what I've got to do.
Yeah, so I guess that's sort of the positives that came with that attention. But clearly there were sort of negatives as well around very strange articles written about you about, buying a curry and all sorts of sort of random things like that. Was that quite challenging, of this newfound attention?
Yeah, that was challenging. And, if you could, it's always better to be anonymous. It changes your life forever when you're readily recognized by a large number of people. Yeah.
And obviously with this newfound sort of interest in public health from the public, how would you say that we can sort of maintain that sort of increased interest and that momentum in people wanting to know about not only infectious diseases, but what public health is as a whole, and even careers in public health? What would you say are the ways to kind of keep that level of interest in public health?
The thing that I think many people don't really realize is the consequences of what it's going to mean for a population that is living longer and longer, accepting that there has been some kind of plateauing of life expectancy in the last few years. But essentially, the longer term trend is that it's a population that's going to live longer and longer, but going to live longer and longer with more ill health for a longer proportion of that total life. And I think when that's quite a stark, general statistic, that in order not to just have a long life full of ill health and disability, we've got to change something about the way we live and the conditions in which we live, the whole kind of exposome, then that makes public health really relevant to, your kids, kids, and everything else.
Yeah, just make it as relevant as possible. So going back to sort of the analogies that you sort of mentioned earlier, and that was probably one of the things that you were sort of famous for in sort of communicating COVID-19 during that pandemic. And as a football fan myself, I was definitely in awe of your sort of style. But as a trainee as well, I was sort of fascinated by, I guess, the behind the scenes of how you develop some of those analogies. As registrars, we're given sort of media training and that kind of thing, and we spend quite a lot of time developing our points and that kind of thing. Did you have a sort of process for developing your analogies? Did you test them out? Did you have to get them approved, all that kind of thing?
As I say, Richard Madeley, I'm going to give the credit for his use of analogies when explaining things to me was a lot of work. It exceeded all of this. The basic question is, how do you explain something complex to somebody who either doesn't want it complex or can't understand it more complex? How do you kind of grind it back down to something they can still understand, still has meaning? And the answer is go for something that's, embedded in the familiar. And that for me was really where the kind of basic idea came from, and the need to create analogies. And for some of them, I did practice them in the sense that I test them on my sister or my wife, only like, 12 hours before I thought I might need them. But I didn't then deliberately weave them into the conversation. They were just kind of up here on this kind of pull down menu. And if it became appropriate, I could kind of pull it in. But I didn't use that. I didn't go out, saying today I'm going to use the X analogy. And there are some that are just still out there in my head that I haven't used yet. I've never used painting a greenhouse in public. You're thinking, where's this going? Where's it? Okay, wooden greenhouse. Okay. They need varnishing, wooden frames, yeah? And it's best to kind of get them varnished in late summer before the kind of winter rain and winds come to protect the wood until the spring. That is just a booster dose, isn't it?
That's good. I see.
Yeah.
That.
Right. Now, you can spend, how long is it going to take you to varnish your greenhouse? Might take you a whole day on a Saturday. Quite a lot of time. Yeah. And you might need to put 2 coats on, actually, if you've let it slip a bit. Yeah. But once you put 2 coats on, is it going to get your greenhouse through until March? Probably. Do you need a 3rd coat? And what's the benefit of a 3rd coat or a 4th coat? You get to a point where you're just getting nothing back other than pain and suffering of doing some more painting, because, the wood's already well protected by several layers at this point. Yeah. And you can frame the idea of, boosting when it's not necessary in terms of just, a coat of varnish. You didn't need to spend the money on a varnish. You didn't need to waste your time painting it, So do what's needed to protect the wood, but, you don't have to do any more. I've never used that one, but that was just kind of there somewhere. There are people who are saying, I want a booster, who JCVI say are not at risk. But I think actually our bigger problem is more that there are people who still need boosters, and uptake is going down over time because people are saying, well, I've had enough of these things now, don't need any more.
So your Royal Society lecture, I would definitely recommend our listeners to go back and listen on YouTube to your Royal Society lecture, where you sort of talked about a little bit about how these analogies came from, and you reflected a really interesting point about great communication starts with a connection to the people you're communicating to, and your 2 connections that you sort of alluded to was your love of your local football team, Boston United, and I think it was your local sort of Army cadets. I guess my question is, what tips would you give to those in training public health on how to develop those sort of communication media skills in a sort of relatable way? It seems like bringing in your sort of lived experience and that connection with ordinary people seems like that's the sort of driver.
If you don't like football, don't try and make football your connection. Just don't try, is the answer. It rarely backfires to have a really diverse approach to life, a really diverse approach to experiences and things and people and situations. And, the richer you can make your kind of lived experience, the more likely you are that you're going to find connections. And so I guess I don't know what it is really. I just don't see any difference. I don't frame myself as somebody who needs to work amongst the intelligentsia of society. I'm quite happy, out in the field, um, creating a temporary shelter under a basher sheet, and relying on things, very basic things like warmth, shelter, physical safety, that kind of thing.
Yeah.
So just get out there and live life. Get out there and connect with people. It doesn't matter who they are, and you don't have to all choose the same thing to connect with.
Yeah.
But look, if you're going to serve the population, which you are in public health, you've got to live amongst them. You've got to understand them. You've got to at least try and feel and experience what they feel.
No, I think that's a great way to end that section. So I remember you reflecting in a piece about the idea of pandemics during our lifetime as trainees in public health, and you sort of reflected that for probably those who are mid-career potentially, or obviously depending on your age, that it's unlikely that COVID-19 in terms of its pandemic level was a once in a lifetime event. So I think you reflected that human and animal kingdom and that kind of thing kind of makes some pandemics more likely in the future. And I said we won't go too much into sort of lessons learned from COVID-19. I think you've spoken at length about that. But I guess one question from a registrar perspective, if you were to leave a note on the desk to the next group of registrars or public health consultants, or even the next sort of deputy CMO dealing with the next pandemic, what would you write on that note as you were leaving?
Get a vaccine as quickly as you can. Don't waste a second in getting a vaccine.
That's very, very clear, and really, again, I guess highlights what you said in the previous question around getting that vaccine industry lens and that link to have in the future.
It was a very bad beginning to the pandemic right around the world. We had no vaccines, we had no drugs, we had no clinical understanding of the disease. What we had to do was break the link between infections and poor outcomes. In other words, between hospitalizations and deaths. Now, you either do that, you don't do that with slowing the spread of infection, because eventually when people do get infected, there's still the high likelihood of a bad outcome. What you do is you break the link either through a vaccine, which is disease modifying and reduces the likelihood of a bad outcome, or the organism itself changes so that it becomes more trivial over time. And whilst COVID-19, SARS-CoV-2 is still not trivial, we do know the lethality of the current Omicron family of variants, the latest being XBB 1.5, or even the BA 2.86, which has now emerged. They don't have the same inherent lethality as the ancestral wild-type Wuhan virus. So the link has been broken a little bit that way. And of course, people now, a lot of us have hybrid immunity, where we've got some vaccine-induced immunity. And on top of that, we've also had COVID once or twice from a wild-type exposure. But what those things do is they break the link between being infected and having a really bad outcome. That's what we have to do.
And that's really your key lesson for, I guess, the next pandemic. So I wanted to talk a little bit about your time as deputy CMO, and obviously during COVID-19. Public health is very political sometimes in its sort of nature, and you've talked a little bit about in the past about the line between science and politics and public health policy making and that kind of thing. I guess what tips would you give to registrars about how to navigate politics and public health, whether that be in national or local government, for example?
Yeah. First of all, accept that our political system means that if you're in public health, you have to work with whoever your population elect. Whether that's your local councillors, if you're a local authority, whether it's your ministers and the government if you serve in national government. But essentially, you have to work with the people that the population elect, and you don't get a choice in that matter. So that's really important. The second thing to say is that you have to keep on asking yourself the same question for each new subject that you deal with. Where's the politics in here, and where's the science, and where is the dividing line? Now, and it can be subtle, but there is always a dividing line between where the science ends, where the public health science ends, and where the politics begins. And you can't just kind of learn that from a textbook. You have to kind of learn it through sensing it and rehearsing it, and sometimes getting it right and sometimes getting it wrong, until your kind of inner being has developed that kind of instinct to know when you're in the political space and when you're in the science space.
So really, developing that instinct to know, I guess, what has the political will and what doesn't. I guess
it's osmotic learning from the wise. That's what's needed.
I guess that's just something you learned from experience when you came into the deputy CMO role of knowing how to do that. So let's get to sort of the challenges ahead. So as part of this series, we're asking all of our guests, looking into the future. There are some huge public health challenges ahead. Climate change, emerging infections, antimicrobial resistance, for example. What do you think are the public health challenges of the future that you think we're not talking enough about?
We aren't talking enough about climate change. It's gone quiet on antimicrobial resistance. Obviously, we've been focused elsewhere. It's too quiet on the whole system of society and government needs to do in the public health space beyond the kind of more narrower kind of public health framing. And there isn't enough constant reminder of the kind of long but more disabled lives that lie ahead if we don't start to change stuff. I think there's got to come a point where more people in the population need to realise that public health isn't about something public health professionals do to them. It's about something they have to actively take part in.
Yeah, exactly. I mean, how do you think, I guess, as registrars, we can act as advocates for promoting, these huge issues in public health when, as you said, there's that sort of the line between science and politics? Do you think we need to be more political as a sort of profession?
I don't think that's the answer. I think the answer is working out, and everyone's different, working out which battles to fight and which things are going to make the biggest difference, and focusing on only those things. There are far too many things in the public health world that are interesting and good to do and useful, as opposed to these are going to change what the health of the population looks like by 2040. That's the challenge. I'd rather us focus on fewer issues and turn the dial on those issues.
Great. So we're coming towards the end of the episode. We talked a little bit about your career and politics and public health. Just going back to the lenses that you've collected across your career, is there anything when you look back that you regret, or an opportunity that you wish you took up but didn't for whatever reason?
When I was about to go to, I'm not sure it's a public health point, but when I was about to go to medical school, a letter dropped. I was going in October, and the letter arrived in September. It was all in French, and it said, "Sir, you are to report for your French military service. Your recruitment number is whatever it was. Please attend the recruitment centre at Perpignan on such and such a date." And I was so desperate to get off and start training to be a doctor that I didn't go. And so I was branded a deserter from the French army for a few years. Couldn't go into France till the exemption paperwork came through. But I wish I'd gone into the French army for 18 months.
Really?
Yeah, absolutely.
That would have been quite an experience.
Exactly. But at 18, you're just too foolish to see that the opportunities that are presented to you that you don't take are often the ones that you most regret.
Would you think, I guess, 18 years old, very, very young and trying to find your path, do you think having that experience would have changed your career and your path? You never know.
Who knows? Have you watched Sliding Doors? Great film.
Yeah.
Who knows? Who knows? But I wish I'd done it. It lives with me almost every day. What would I have learned from that I now can't learn age 60?
Oh, that's really, really interesting. Great. So we're coming towards the end of the episode. It's a tradition on the podcast to end with a career tip. So what is your one career tip that you would give to those currently training in public health?
One career tip is take your time to find out what you are really good at before you settle to a longer term career move. Take your time. 18 months might seem like a long time now, but when you're my age, it's not.
Great. Well, that's a really good note to end on. And it's just left to say thank you so much for joining the podcast and allowing us to sort of delve into the background of your career. And thank you so much for joining, Jonathan.
All right. Good. All right. Nice to see you.